You.
All right, yourself.
I'm well. Hi, Terry and Cliff. Feel free to come to the stage and introduce yourself and join the conversation. We are no strangers here. We're all one big family. How's it going? How was the whole full week? Was it a full week? Or no, you don't start until December. That's right.
Yeah, I saw it in December.
So we got some pages to the manual, right? The ebook, right?
We didn't get pages to the ebook, but we did get. I did make some headway with Tableau.
Oh, well, look at you. How's that going?
It's coming along. I mean, I met because I got my the position I got through networking through a friend of a friend. So I was talking to her about some data analytics things that I wanted to do once I started.
Uh-huh.
So she's like, okay, well, why not go for it?
Okay.
So,
Good for you. Good for you. So, the elephant in the room. That information that you sent.
oh,
Oh my God. Amazing, amazing. Um, let's see. First, I do want to mention that we are recording, so folks in the room know. I think I have it that says recorded in the description, but just to let you know before you come to the stage to speak, that you know that it is actually being recorded. Second, I went to the CPT symposium um, over the last couple of days. It was actually fun. It was actually one of the better conferences I've been to virtually, because you got to go to everything. So they didn't separate. Normally, conferences, you have your breakout rooms and you separate. But in this particular space, you got to see every single thing. So everything went back to back, unless you chose not to go to a particular room. You were in every room. Um, and the one thing that I know you would be so interested in, and I'm still curious how they're gonna pull this off, for two reasons. But in 2023, the evaluation and management codes are going to be revised in the emergency department. And the reason why I'm curious how this is going to, well, two things, I guess, because I've recently seen a lot of chatter and information about CDI in the emergency department. So
okay.
that's one thing. A lot of stuff bubbling about that. The second thing is that you and I both know that the emergency department evaluation and management codes are dual purpose. They're used not only for their intent was always technically to use it for the provider when billing professionally for the provider, but they're also used for the facility.
Right.
And the facility doesn't use it the way it was intended. So they put together their own logic, method, flow in order to determine the resources that have been used for the various levels. And it's not regulated. It's facility specific. So there are lots of software that, well, I know one or two big ones off the top of my head, but there's some software out there that assist in leveling those services. But again, it's based on how the facility plugs in the information on the resources to determine what the level of ED is going to be. So I am extremely curious how that's going to shake out when they change it, and how they're going to change it. And maybe they'll split it. I doubt that, but to me that seems a logical choice. But who am I?
Right.
Who am I? Nothing logic about it. Yes, yes.
That's really interesting.
Yes, yes. So they were like, it's going to be for the changes will occur for the emergency department, and I believe it was observation services were the two that they're going to target next. So hopefully they will do a great job next year to spill out, information and guidance so that people can be prepared for 2023. I think they did a relatively great job with the office visit E&M preparation so that, providers can be trained, staff can be trained, people can understand and know what's happening. But we'll see how this falls out.
You know, well, it's interesting because as we all know, E&M leveling is very subjective.
Mm-hmm.
It because two people can look at the exact same encounter and see something completely different.
Mm-hmm.
And there's a lot of gray area. So I'm not surprised, but I remember years ago I read that that ultimately they were going to try to change outpatient into like a value based or risk adjustment type of payment system. Period. So I think that eventually all of this is going to be done away with,
Mm.
and they're going to move to like an ICD 10 base because right now outpatient is based on the CPT code drives the payment like it's the ambulatory payment classifications.
And the
So
RVUs, yeah.
right.
Mm-hmm.
And I think that if they're going to try to change it to more like HCC based and on the outpatient, then it's going to be like it is DRG based and inpatient. So I think ultimately that I don't know how they're going to do it, but I think these are like the first baby steps towards that.
That's going to be interesting. That's going to be interesting.
Then did you also see that they released some Z codes that are going to go into effect April 1st of next year?
I did. I did. My video is coming up. I recorded it the other day. I'll be dropping it probably on Tuesday before the holiday. I
Okay. And
did.
I'm like, we all know where that's going. We all know what that's about.
I've seen so much talk about that as well. Like, are they targeting us? Are they, it's like, what's the purpose of that? Because
Oh,
there are no
mhm.
other conditions that require vaccinations that specify the status. So is this, where are we going with this? And so that's going to be
Mhm.
real interesting. A lot
Oh,
of conversation about that.
we know where it's going.
Well, I know. Oh, I can't think of the country. There was a country recently. No, I'm not going to do that to myself. I know there was a country recently that announced that it will no longer be providing. No, they didn't say they wouldn't provide medical care. They will no longer be footing the bill for medical care for people who are unvaccinated in that particular country. And so I don't know. I don't know. But you got to think about, ICD-10 is not just for the U.S. It's worldwide
Right.
until next year when 11 kicks off. But it's worldwide, so that you can't think that it's necessarily just for us.
Well, that I think that is because aren't they? Because there's a lot because that's specifically for us. Don't you think? Because those are those are CM adjustments. Those aren't. You know. You think those are like codes that they're going to use worldwide?
I think I mean, they'll be using them until they flip over until 11, and then I don't know if they will necessarily add them to the 11 codes. I don't know. But usually you have, I don't know. I need to go look. I'll take a look and peek and see if it's out there in 11. That'll be interesting to see. That'll be interesting to see.
I definitely think that it's for more than just statistical purposes.
Well, my public health um, person in me, the public health student in me says that this is going to help us statistically when we have to put together programs and do all kinds of things for people. So it will help us determine um, who was vaccinated, who wasn't, if there are outcomes, etc. Like, for example, when they give the statistic, and I know it's kind of loose, I guess, when they give the statistics about people who are now being hospitalized, and the majority of them are unvaccinated. Well, this would give some definitive statistics on what that number looks like. But then you still there's still I guess if you a trust factor, if you will. I mean, because I've also heard that people, they're taking or obtaining vaccination cards that don't necessarily belong to them, or they're telling people that they're vaccinated and they're not, or there's all kinds of things going on in the world. And so how all of this impacts all of that, I guess, will be interesting as well.
It's I'm just, it's like you started off. This is the first time for any kind of vaccination they are tracking something so intently.
Mhm.
And I am, I think I think the complete opposite. I don't believe that it's for our benefit. I believe it's for somebody's benefit, but it's not us, because I just think that the
You mean
entire
us, like the
situation,
patient, or us, the healthcare community?
well, for us, the patient and the healthcare community, because I don't see how me know how. I mean, the codes are very, very specific,
Hmm.
like partially vaccinated,
Hmm.
um, other what is it? Other immu- basically other lack of immunization status,
Under
and I'm
immunized, under
right,
immunized. Hmm.
right, and in my mind, that says to me, because I just can't wait to read up on what the criteria is, because that says to me, because there has also been talk that if you don't get a booster, you're not considered fully immunized. So that would be for somebody who has been vaccinated but hasn't had a booster.
Really? I hadn't heard
That's what
that.
I'm thinking. I could be wrong, but but there are talks that I have read that they're trying, in certain places, like they're trying to in England, matter of fact, the UK, if you don't have a booster, there's been talk that you're considered not fully vaccinated.
Really? Hmm.
And that's a slippery slope, because not everybody needs to get a booster.
And in some instances, boosters haven't. Well, there are certain they haven't been developed yet. So, certain vaccines that, I mean, we have the vaccines that we use here in the U.S., but there are other vaccines that are being used in other countries, and some of those vaccines, the boosters haven't been created. So, wow, wow, yeah, it's gonna be real interesting.
It
Okay,
is.
so let's talk about the elephant in the room. so, so the article that you had, that was a doozy. I was like, oh my goodness. And I think there have been um, providers that hey Franco, feel free to join to come up and speak. I think there have been provider or physicians, I'll say physicians who either been suspended or possibly I don't know if
Yes.
anybody's lost. I know they've
Yeah.
been suspended.
Yes.
Wow. So tell us a little bit about the article for those who don't
Okay,
know.
so the article is it came out from it was an article that was published by the National Council of State Boards of Nursing,
Hmm.
and that organization regulates all RN and LPN programs, licensing, codes of conduct, all that. And this national council gets together and they have resolutions. So they came out with the resolution on Monday, I believe it was,
Hmm.
that any person who identifies as a nurse that is on social media and they are giving information and talking about COVID-19 and disseminating information that is not based in science and that is not based on sound medical practice, they would be in jeopardy of losing their license and their nursing career because the individual state boards of nursing will come after them. And in a lot of health occupations, in a lot of professional licensing for healthcare, there's always in any occupation really there's a code of ethics, but
Correct.
in nursing they really push it, and in medicine they really push it. So that would be a violation of ethics, and you can. They're saying that you can lose your license.
Wow. Interesting. So, are they going to be out there monitoring, or is it going to be something like,
Oh, I'm
I
going to
hate
tell
to
you how
bring
it's going to
up
happen.
the state of Texas and that whole foolishness, well, all the stuff that they got going on in Texas, but is it going to be something like, I can go tell on somebody, look, I
Yeah,
see them saying
yes,
so and so, and let me
yes,
go point the finger and send you their link so you can look and see.
yes.
And wow.
That's what's going to happen. I've already
Wow.
seen videos about it. I've already
Really?
seen. Yes, I already saw a nurse who, because that's how I found out about it. It was on TikTok, and she had a link to to the article and everything, and she said, "Well, I've been compiling a list of people of nurses who have been on at least on TikTok, disseminated information that they felt as though wasn't based in science." And so, yes, it's going to be a whole lot of tattletaling and dime dropping.
I mean, I feel some sort of way. And one way is at I know that nurses have an ethical um, responsibility and duty um, when they, and I know they don't wear the hat, but I'm figuratively, and when they put on that hat. However,
Right.
they're not nurses 24 hours a day. They're people first that have selected to be nurses as their profession. Um, and at what point is there a slope, that slippery slope where I'm not speaking on behalf of my profession. I'm speaking as an individual or my opinion. Like, so does their opinion not, uh,
Here's what it is, and I see your point, but I also understand the National Council of State
oh,
Boards
I
of
get
Nursing.
it. Trust and believe, I get it. Because I've seen some egregious stuff out there. Like, are you kidding
Right.
me? And they said that they're a nurse. Don't get me wrong. I totally get it. But I'm playing a little devil's advocate, but I'm just, just to say, at what point is there an overreach? But go
Here's
ahead.
what I think. I think that if you don't identify as a nurse and you say that's your opinion, that's fine. But I think that the minute you identify as a nurse and give your opinion, then you have at that moment, you can
You cross
influence
over.
somebody who is not a nurse because then they think, oh, well, this person knows what they're talking about because they're in healthcare, because they're a nurse.
But what if
And
somebody, if you don't necessarily identify, but somebody knows she's a nurse, and then maybe even in the comments, they're, oh my God, she must know because she's a nurse.
let me that I can't. I would have to see an individual um, situation, because most nurses, when they get on a platform, they want everybody to know that they're a nurse, and so they disclose it. If they don't disclose it, nobody would know. Now, if somebody,
No, I'm
if
saying
they're
somebody who they treat, somebody who knows that they work in the hospital or knows them personally and knows that they're a nurse. Not
oh,
that's what
but
I meant.
I think that's fine. I think that as long as if you're saying that you want to take, a medicine that is used for animals, and you believe in that, I believe that if someone does know, and if I make my post and I don't identify as a nurse, I'm giving my opinion, I don't think that they could come after that person, because that
Okay.
person is not hasn't nobody else would know that they're a nurse.
Okay. Or they haven't disclosed that they are speaking
Right.
as in a professional capacity. It's just their
Right.
opinion about XYZ. So I can see the disclaimers just flying.
Yeah. I mean, that's what I would do.
A whole scrolling disclaimer. So yes. Wow.
Because I just think that around the messaging around this disease has just been lost
Yeah.
from the start. It was just it's a runaway freight train. It's a hot mess. And I have been I've been in healthcare for 28 years, and I'm still on the fence about a lot of things. So I can imagine how a layperson thinks, because it's just you cannot get any clear information, and
Right.
that's sad. It really is. I know people personally who have had adverse reactions from the vaccination, but you will never, ever, ever turn on a TV and hear any definitive research about how many people and what type of adverse reaction someone has had, other than um, blood clots with Johnson and Johnson in females between, I think, it's 18 and 49.
Mm-hmm.
Other than that, but I know people who have had strokes and everything else.
Oh wow. Wow. That's interesting. I don't know. I just the more this goes on, the more it's being revealed, the more we have to learn. But that when I saw that article, I said, "Whoa, Nelly."
Oh, it's get those in certain states, those nursing boards are going to be inundated.
I
You hear me?
know. And they don't play. And then I think, yeah, that's gonna be interesting how all that plays out and how aggressive the nursing boards are toward. I mean, because it's kind of because you're already in a state where you don't have enough nurses. There's a shortage of nurses. Um, they're either leaving the profession for whatever reason or retiring out of the profession, and now you're about to create another avenue to reduce the numbers that you have. Um, with with justified reason, I get it, justified reason, but wow. But then I guess that had to be a lot when they even made the decision to go this route.
Well, what I think is, me personally, I don't believe that they would take anybody's license, because you don't know if anybody has suffered harm directly because of what they said. You don't know.
Mm.
So I think that what they would do is maybe give them some kind of sanction, or like they'll have to pay some type of fine. That's what I think.
Mm.
But to take someone's license, I don't know. That's a drastic step. Now maybe if they have some repeat offenders, then that might it could lead to that. But right off the bat, I don't think so.
Right.
And given all the reasons that you just said.
Right. Wow.
I was just shocked because normally, like, they haven't said anything during this whole pandemic. So for them to come out with that, I was like, I mean, I was shocked. Because they, but it's just it'll be interesting because I know, man, I know there's some nurses who have a whole dossier of people, recordings and everything that they're just waiting.
And they're gonna be flooded. Oh my God.
They are.
Oh my God. But then yeah. But then what if there's, somebody who has a vendetta and is out to get somebody, and that's a mess. So is there a cutoff, like, or is there a starting date, like from this date forward, or is it anytime? If somebody
it didn't like, I didn't see a clear start date, so that's why I think that it might be left up to the individual states.
Okay.
So I'm sure that they have gotten a flood of calls already at the individual levels, and I haven't received anything because I'm licensed in Pennsylvania and New Jersey, so I haven't received anything for any kind of email from either board yet, but I'm sure one is coming.
Okay. Wow. Whew. Yeah, that was good.
Oh yeah, I mean, that was, social media was a blaze earlier this week.
I think between that and the COVID-19 status codes, yeah.
When I saw, because those two, well, I was like, what is going on? I'm like,
it's serious out here in these healthcare streets, huh?
It is.
More than we knew. Like, wow. What else did I see? Um, um, yeah, I did my video this week on the codes that were released for the vaccines for children. So CPT has put those out, and so I just released those or introduced those. Trying to think, what else was some alarming big news from the symposium? There was lots going on with cardiology. I was like, well, you have to when you specialize in cardiology, you own to something. It's a lot.
It is.
Oh, the one thing that I did notice, and I mean, I guess this is more a fight for the providers, but like they have a recommended for the RVUs and the scores, they have a recommended amount. And then CMS kind of has their recommended amount, and then they have what was actually approved. And in the majority of the cases that they were showing, the majority of the cases, I guess they were kind of even. But there were several cases where it appeared that the work for the different codes and the procedures was higher. And so the AMA or the council that reviews that kind of leveled them at a higher score, and CMS was like, nope. And so they were getting like the short end of the stick on a lot of those. I was like, ooh. And they were actually like category 1 CPT codes. So they were the ones that were actually there. They're not necessarily the temporary codes. So it's gonna be interesting how all that works out too. Yeah, and
Well,
then they
you know,
did.
but
Go ahead.
no, go ahead.
They did. They kind of did a deeper dive on the E&Ms for the office. There are lots of questions. Even after they came back in March with their technical revisions, there were still some questions. And I think the one thing I wanted to take away was, um, I'm truly an optimistic person. I believe, you're looking for the good in everybody and what have you. But then I know just from my compliance background that there are some bad actors out there
Dumb.
who are intentional in what they're doing. Even if they even if they're quote unquote not a bad person, but they believe that what they're doing is right and they intentionally continue to do it even after they have been told otherwise. I'll say it that way. So it was amazing that a lot of the providers so they would have these Q&A sessions um, after each of the different specialties. And so they had like 2 or 3 E&M kind of Q&As. And at all of the Q&As, you had the physicians who worked and presented in that specialty. But you also had the medical directors, the MAC medical directors or CMS medical directors there to opine and provide information and answer questions as well. And so it was like, the physicians or providers were, like, well, the intention was this, and providers would never do so and so and so. I'm like, really? And then, the even the medical directors would be like, well, I know the intention, but maybe there needs to be more education, trying to kind of smooth. And then, like, the people in the comments who primarily are those who are either coders or auditors or in the profession who's dealing with these codes on a regular basis. I mean, the comments is flowing like, really? What? They don't know. Da, da, da. And I'm like, ha. It's like they may be a little out of touch.
A
Or
little.
again, like me, want to believe the best in everybody and that they wouldn't necessarily intentionally plus you're dealing with CMS. I mean, how you gonna be like, yeah, I know so and so and so, and he intentionally tried to defraud you. So I don't think you want to go down that route. And then I was
Well,
even watching the comments because people, because in the comments it'll have your name and it'll have the organization that you represent if you put that in there. So it's like, don't do that.
right.
Watch yourself. Watch yourself.
Well, what I think needs to happen, and I don't know if it will happen, but medical education in this country has to change. And it has to change so these new providers, when they come out into the field, they need to at least have some kind of knowledge of documentation, have some knowledge of how it all ties into how it can affect reimbursement. And I just know, like when I worked you know, in hospitals, especially in teaching hospitals where you had a lot of new grads, like they need a lot of hand holding. Like they can't even write orders correctly. So there's a lot of correction that has to be made, and I think that would be the best time to really really drill into them why you're doing what you're doing, why it has to be documented this way, why do you need to specify XYZ? Because what happens is when it's for people who don't come up in an environment where that kind of dialogue is fostered, people develop habits, and habits, as we know as human beings, are very hard to break, especially once a provider climbs up through the ranks and they have a little bit of notoriety in their specialty or in their area, and it's just hard as heck to get them to do anything they don't want to do. It's
Yeah.
like dealing with a a 40-year-old that's like in the terrible 2 stage. It's just it's a lot. It really is. Like, I mean, especially coming from a you know a hands-on practicality standpoint, I've seen it. You know, it's hard to get them to even change your order, let alone, you know, specify or I can imagine how they respond to some of the coding inquiries. But I also I also blame, and this is the only aspect that I think this is the only area where I think nurses kind of have a leg up on regular coders, because a lot of people in this country do have a reverence for doctors that nurses don't have, and nurses don't have a problem confronting a doctor, whereas a lot of people are intimidated. But a lot nurses, I mean, listen, it goes down in those nursing stations and on those telephones in these hospitals. Trust me when I tell you.
Mm-hmm. I've seen it, and I don't. I think I don't. I don't have. I don't share that same reverence. I think I mentioned that last week. Like, I feel like I'm here as a resource. I'm here to help you. You put your pants on one leg at a time, just like I do. So,
Right.
let's get to the bottom. The bottom line is there's a problem. We need to address the problem, and let's do that. I know when I worked at an academic medical system here locally, and in their compliance, I was in compliance education, and one of the things that we did was we got in front of the residents with kind of an overview of, and this is years ago, so things have definitely changed, but we got in front of them doing just as you said, providing them information about documentation, providing them information about evaluation and management, just that whole, what that looks like and how that ties into their documentation. So we would get an hour, and unfortunately it was just an hour. We would get an hour with them during, I don't know if it was part of a rotation or something, but it was something, and it was mandated that they had to attend. And then the other thing that we kind of pushed, and we went to the various chairs of the department, and they agreed and they were okay with that, was every year they had to have some sort of documentation, education, even if it was a refresh or what have you. And so not only did we bring any changes that could potentially impact them as it relates to their documentation, and we were, it was all primarily, well, it was both, because you had some who did, outpatient or had their own practices, and then you had those who were actually in the hospital doing hospital work. But we provided the information related to that, as well as the regulatory information. So this is how it ties, and this is what could happen, and this is what they're saying that they're looking for. And so we would also bring like information from the OIG, Department of Justice, that type of thing, to show them like, yeah, there are some intentional folks, but some of this stuff is kind of, it was a mistake on your part, but a mistake that someone who's doing this work for you as it relates to coding, filling, that type of thing, should have known. But at the end of the day, you're liable. So you should know, or make sure you have the appropriate people in play doing that work for you. And so it gave them a heightened awareness of making sure that they're doing their part, because yes, and this was way back in the day before it was unheard of that they would come after billers and coders and those people, even though they do it now. It was unheard of then. But at the end of the day, it was like, they're looking at you and they're going to target you. So make sure your stuff
Right.
is what it needs to be. And that's still the case today, even though there are some folks that fall below the provider that can be intentional in not doing the right thing. So yeah. So you're right. I think, it's a matter of getting to these newer providers early and educating often. So it becomes part of practicing medicine for them, that documentation. And that's one thing about nursing, I will, say and caveat. I mean, y'all put it down on paper or in the electronic. Y'all writing it. Y'all talking about it. Y'all telling it.
Yeah.
You're telling the story. But when you look at the an office visit, or if you're going outside of the hospital, because the hospital is where you have the majority of your nurses and you have that whole nursing documentation section where you can go through, like if you look at stuff, you'd be like, let me go see for real what happened here.
Right.
And read some nursing notes. You don't have that in an office setting, usually.
No.
And so at that point, you're at a disadvantage, which back to your overall point of CDI is where that truly is needed, because you don't have that middle person per se adding that additional stuff. So you have like a medical assistant or whoever comes in, and they're just giving like a brief information related to their conversation with the patient and their vitals and that kind of stuff. You don't have that additional level of documentation, I think, that you do with that piece is missing in an office setting. So you can't be like, well, let me see what the nurse said, because a nurse may not have seen that patient unless that nurse was actually being their provider in a nurse practitioner or something. So yeah. Wow.
I think that it's a great time, because I can see slight improvements.
Mm-hmm.
I really can overall, like when I look back on, because can we be very clear? Like, I think it's very funny how any provider would say when somebody where somebody was not intentionally trying to defraud or be fraudulent in their documentation, when can we be very clear? The reason why we have all this regulation is because providers were robbing Medicare, Medicaid, and these insurance companies like deaf, dumb, and blind.
Correct.
I mean, that's how it all started, because, I mean, back in the day, it all started pre-HMO. Like,
Correct.
whatever the doctor said went.
Correct.
If he says you needed to be in a hospital 5 days, you were in a hospital for 5 days.
Exactly.
There was no questions asked.
Exactly.
And when they started with HMOs and utilization review and things had to be approved, they haven't been the same since. But the only thing that is shocking to me is, okay, they have cut down on the amount of money that is wasted,
mm-hmm.
per se,
mm-hmm.
but then these insurance companies, like their CEOs, are raking in millions in salaries and bonuses, and I'm like, so it's just a redistribution of money, but where are patient outcomes any better? And I don't really know if we can really even say that healthcare overall has improved. I think that counting the money has improved, but I don't know if outcomes are any better as a result of all this regulation.
Well, I think that's the quality piece is where I guess the next rung on all of this, and setting those. I think the medical societies in and of themselves need to potentially play, and I won't even say that. My first thought was the medical societies need to play a bigger role in establishing some standardization as it relates to protocols and all of that. But I think they do, but then people don't necessarily follow them. And then, I think in medicine is very competitive in certain specialties, very competitive. And so somebody always wants to be the first one to invent this or to do this procedure or do, you know what I'm saying? And so I think sometimes while there are set things that you can or should do that have been spelled out by these medical societies, you just have folks that be like, okay, I see that, but let's do this or let's try that. Or, maybe even the patient presents with something that, I mean, you see it. I hate to say this on TV all the time. You see it where they're like, okay, yeah, they got this, but let's try this or let's do this. And this is unprecedented. And this is, and I trust me, I know it's TV, but there's truth in that. There's truth in that. So I think that kind of shifts the whole quality dynamic, and you're right. I mean, we have not, I don't believe, have achieved the level of quality in healthcare here in the United States that I think we could have. That's possible.
Well, go ahead.
And where the money is going, that's a great question. Follow them dollars. That's a great
because we cannot, there is no, what I find very interesting is nobody in everything that we talk about in coding, everything we talk about in healthcare, nobody ever ties this directly to food. And our food system, our dietary guidelines. I mean, there are a gazillion documentaries out here that talk about the food supply, that talk about where we get our dietary guidelines and who is behind it. And almost like the top 5 diseases in this country, a lot of people say can be not necessarily cured, but can be mitigated by dietary changes.
Yep.
But you have, in case in point, one of the most interesting things as a nurse and a coder that I've seen is no doctor ever comes forward and says, I recommend a low carb diet to my diabetics. But when you read documentation, when you read their notes in their diabetic when they're diabetic patients, they tell them to reduce carbohydrates and sugar. But they will not go out and publicly advocate for a ketogenic diet, which is interesting to me.
Well, so I don't know I think I told you all. I'm a caregiver to my mom who's diabetic and had some challenges at the beginning of last year, which is how I became a primary caregiver. And those were my questions, about her diet, about what can we do to get her blood sugars regulated, all of those things. We're in constant communication and dialogue about things. And everybody, it's funny because everybody's like, oh, she got the right one now, because the compliance person in me says, here's the rule, this is what we're going to do, and this is what you're going to follow. Don't ask me no questions.
Right.
But one of the things that, it was a nurse practitioner that came to me and was like, we need to make sure that she is following a low carb diet, and this is what that looks like. And provided me with some resources on doing that. And I like to call myself a vegan friendly vegetarian. And so, everybody's like, oh, so you're going to convert your mom to vegetarian? I was like, no, I'm not doing that, because trust me, there will be a rumble in this house. That's not going to go down. However, I can make sure she has, she's eating more fruits and vegetables or things within the glycemic scale that is appropriate for her and her carb level. And so, yeah, because ultimately, and I'm like you, there have been a lot of research on this where, you know, people who have been on a lot of medications have been able to get off medications just based on their diet. And it's amazing. It's amazing. And to your point, it's really, it's not necessarily simple, but it's elementary. Let's start at that bare bones. This is something that everybody's going to eat. So what's the common denominator? You're talking obesity. It's food. And so let's take a look at the food that people are eating. And then you have a whole big area around that, especially if you're looking at like the social determinants of health and people who live in food deserts, or it's another word. It's not a food desert, but it's a place. The definition is a place that is saturated with fast food places or convenience stores. So they don't have a true place where they can get fresh fruits and vegetables and, you know, great meat and seafood and that kind of thing. They just are surrounded by fast food. There's a term for that.
Right.
And so it's interesting even in that. And hopefully they had a whole big session. That was another thing. They had a whole big session at the symposium that looked at the social determinants of health. And using that to help with the health outcomes of the patient. Because if you know more about their background, you know, you're coming in thinking, hopefully not thinking everybody is the same. That's a problem. But at least you're probably coming in thinking that everybody possibly has similar access or similar things are available to them. And it's not. And so if you take into account some of those external factors that may be in play, that, well, they can't do this or can't get this because of XYZ, then maybe you can frame, you know, the conversations that you're having with your patients on what they can and cannot do, or provide additional resources, or connect them to the appropriate resources that can help them, that will ultimately better them and their health outcomes.
But, you know, I don't know what the medical school curriculum is, but I know, like, in nursing school, one of the first things they teach you is there's a whole class on dealing with your own bias and how you have to basically because we all have them, and how you have to put them aside when you care for people, because you cannot assume that somebody knows what you know. Right. You cannot assume that everybody has had the same experience as you. Yep. And, you know, so you have to approach people from that standpoint. And I don't find that in healthcare, period, because I just know, like, like most people, especially most Black people and most minorities in this country, I've had good healthcare experiences and I've had some not so good healthcare experiences. And I'm a nurse. And I never, ever, ever tell anybody I'm a nurse until I need to.
And it's just unfortunate, because then it changes. Things change.
Exactly.
Like if I'll say I'm in healthcare compliance, things change. Like,
exactly.
You know, and I'm like, but I shouldn't have to. I should be just a regular person walking in trying to receive the same services from somebody else. It shouldn't have to be that way.
Exactly. And you have people who still to this day, oh, well, that's what the doctor told me I had to. And there's no kind of, like, nowadays you really have to have, you either have to advocate for yourself, or you really, really have to have an advocate in your family, or otherwise it'll just be a mess. Yeah. And I know, like, I think I might have told the story before. In 2017, I had sepsis. And when I went to I was in the hospital for 5 days. I mean, I was sick. So I started feeling better because I was getting freaking round the clock antibiotics. And so I was admitted on Monday. So come Friday, I mean, I felt great, other than, you know, the diarrhea from the antibiotics. So the doctor comes in the afternoon and is like, well, we're thinking about discharging you, but we have to wait for your blood cultures to come back, and you're going to have to continue. You're going to have to continue on your antibiotics. He said we might have to put in a PIC line for you to, and then once we put in a PIC line, you'll have to. You can either go to an infusion center and continue to get your IV, or we can train you to do your IV therapy at home yourself. So when we got the third option, I said, we're not doing any of that. And I told him, I said, if you think that I am supposed to, and you think that I still need that kind of that kind of intense IV therapy, I'm not going home. I have insurance. What you're going to do, if you want me to leave the hospital, and I get it, if you want me to leave the hospital, you're going to send me to a skilled nursing facility for another 7 to 10 days for me to complete my treatment. Mm-hmm. Or I'm going to go home on a PO antibiotic. Guess what? I went home on a PO antibiotic.
Right, I go set up all of that. Wow.
And then it wasn't until my nurse came back in the room. She said, do you work in healthcare? I said, yes. I said, I'm a nurse. Why? She said, when you said PO antibiotics, she said, that's when I realized. She said, most people don't say that. Because by then I was in my feelings. And but I said, yes, I am. I said, at that time, I said, I've been a nurse for over 25 years. Yes.
Yeah. You're right. And it takes all of that to advocate for, and in your case, your personal health, but then with family members, to have somebody to help advocate on their behalf. It's like, wow.
Oh my! I've done it for family members for years. I mean, most of them done gone on to glory, but I mean, while they were here, oh my God, it was a mess. But you really do need people, because it's just they just get lost in the sauce, and they don't question. They don't think they can question. No, somebody has to explain it to you.
And the importance of right, because I often feel like I'm a translator, right, or interpreter,
right.
Like, okay, he said la 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 la, and then they'll tell me, and I'll be like, no, he said, because they'll just be like, okay.
Exactly.
Usually it's like, I don't really want to be here. I'm here because, I got to be here and I just want this over. No, would you listen and pay attention and whatever, so so we got to do better as well.
But a lot of us don't even really know, because you have people who, I mean, most people, I mean, to be honest, like most, it's not like, oh my God, I'll just, I've always been waiting for this opportunity. It's just, you do it because you love your loved one. Correct. And you want them to be taken care of, and you want them to be okay. So you kind of fall into it. Yeah. But the thing is, you should never even have to fall into it, because there should be support. Like, you should have, like, a provider should say, well, can I call your son, or can I call your daughter? Or I need to talk to so-and-so so I can make sure you understand what's going on, but they don't. Mm-hmm. And I get it. And I understand that, to that, to my aunt or my mother or my cousin, you might look at her and just see that's $100 visit. Mm-hmm. But that's a loved one to me. Mm-hmm. It doesn't mean anything. They don't mean anything to you per se, but it's just It is just crazy, the things. My aunt went to a cardiologist, and how are you a specialist? And when I signed her in, we had to wait for over an hour to get called into the back to be seen by him. Wow. So I try to be nice. I'm like, well, doctor, when you finish, can I have I need to talk to you for a minute. He rushed out the room and went into another patient's room. Now, me being me, I went in the room, because he had the door closed. I opened the door. I said, I told you I wanted to talk to you. We could either do it in here or out in the hallway. He came out in the hallway. And I told him, I said, my aunt thinks that you're a good doctor. I said, but I don't. I said, because you're a specialist. Why is somebody having to wait for over an hour in a lobby to see you? I said, if you have that many patients, I can make a phone call and her insurance can make you thin down your roster. Can I tell you, no lie, the next time she went for her appointment, I could, by the time I signed her in with this and went and sat back down, they were calling her to the back.
Yeah.
But people don't know. You
They
can do
don't
that.
know, right.
Insurance companies can tell you that they can make providers close their enrollee list. You can't take any more people.
Yeah, clearly you got too much. You're doing too much.
Exactly.
Wow.
Because patient care is starting to be compromised, and that's not what they're paying you to do. They're not paying for half behind treatment. You're not billing for half behind service.
That's right. That's right. And then I'm one that's always looking at the documentation, or what y'all trying to bill? What y'all doing? What is this? We didn't do this. We didn't do this. Let's revisit this. And you're like, oh my God. Here she comes.
And people don't know that you can do that either.
You can do that too. That's right. Like no. Explain to me how you think you're gonna get this off, and I saw you for 10 minutes max. Explain that.
But another elephant in the room that I don't know if you would want to address, but I think that it's important, especially in anything dealing with healthcare, but especially in coding. We need to talk. I think that the elephant in the room, we need to talk about how to negotiate salary.
Mm-hmm.
Because so many people don't negotiate at all. And it really does limit the amount of money you make over time.
Yeah.
And I mean, I learned how, and I still am getting better. But I mean, I started years ago, and I remember I was doing it even before I heard of this case in New York. I think it was New York Presbyterian. It was either New York Presbyterian or NYU, one of those big hospitals.
Mm-hmm.
There was a class action lawsuit by these Black nurses.
Mm-hmm.
They had filed this class action lawsuit saying that they were not paid on the same level of the white nurses.
Mm-hmm.
Well, during the case, during the hearing, it came out that the reason why the Black nurses were paid less was because none of them negotiated their salary. Whatever the hospital quota was, what they accepted.
So basically, like you didn't advocate for yourself.
Basically.
We weren't gonna push it, but you didn't advocate.
Right.
Mm. Yeah. I mean, and with most positions, with all positions, there isn't this is the rate, period. There's a range.
Right.
There's always a range.
And people
go ahead.
Go ahead, I'm sorry.
No, go ahead.
And people don't realize that the quote that you get is always going to be the lowest. Always. I don't care whether you've been in something, whatever the range is, what they're quoting you is on the low end. Right. Period. You can just make that assumption. And you have.
Go ahead.
Oh, go ahead. I'm done. Go ahead.
No, I remember being on the flip side of that. You have a range, and that's the opening starting range, but then you have a wider band, and that band kind of is put there to kind of move you through. So say you make a career at that particular position. So, you're given, these annual increases to kind of move you up through the band until you max out. And then when you max out, then that's a whole other conversation. And I've always been like, well, I remember we had a conversation with, I don't know if this person was already a hire or we were in the process of hiring, but they kind of knew the whole kind of HR game. And so they knew like, well, I get that this is the starting, range that you're offering me. But what's the top of the band? Because then she knew where she could play and what she brought to the table that was needed and was necessary and how to be compensated for it. And and I heard a lot of, well, you don't want to be at the top of the band because that means you'll max out and you'll never get another increase and blah blah blah. And that's that's just saying if you choose to be at this job with this company for X amount of years, that may not necessarily be the case. They may not necessarily have the goal for you to be in that position at that company for long gone are those you're going to be here for 20, 30 years in most cases. So
that's right.
Her thing was, for lack of a better term, don't save mine for later. Give it to me now.
That's right.
So yeah, you're absolutely right. There should be some sort of information and education around salary negotiation. I guess that's for any position.
But I've seen it, and especially because that's another thing that and basically when I came on into HIM, which is the other side of healthcare, I'd already been, because when I tell you nurses argue for every alcohol soaked dollar they make for the most part. And I know I was a pro because I used to work agency, and if I found another agency was paying $1 an hour more, I was like, where's the office? I was going to get my money. So it was a whole different, I came at this with a whole different situation. And there are times when it might not be in your best interest or maybe to not negotiate. There have been times that I didn't negotiate because I knew, like for me, I wasn't trying to haggle and I'm not trying to go back and forth. I just wanted the opportunity and I was going to make it do what it was going to do. And because my intention was to never stay there. My intention was to get a job, to have that title, and then I was going to get what I needed to get somewhere else. Mm-hmm. So that's also a strategy that people need to know, that you can do that too if you so choose. But you have to know, if you're not going to go back and forth, that you need to set a time frame to how long you're going to be at this particular institution. Yeah. And then move on, because you're never going to get what you need to get. Like, they're never going to give you a 10% raise in a year. That's not going to happen.
Never. Ever.
So you just have to be smart about it. And it really comes down to, like, a lot of people have to know that these coding skills and CDI and compliance, they are valuable in the marketplace.
Yes, they are.
Valuable. You can pull down some money. Yes, can. And you cannot be afraid. And one of the best quotes I ever heard from P. Diddy of all people. He said, if you are not afraid to walk away from the table, you are not negotiating. And that is true. Yeah. I have had job offers fall apart over money. It's plenty of them. But guess what? I would rather lose a job and go on and get what I need from someone else than work somewhere where I know I'm being underpaid.
And then if you're being underpaid, then you're not being valued either. That's
exactly.
That's a whole conversation around that. But you're absolutely correct. That's, so one of the things that I'm wondering, as a result of the pandemic, you have a lot of jobs that their salaries have been adjusted, and rightfully so. For example, the like in the food industry. So, where they were making pennies and tips, they've now kind of reconvened and readjusted and, are giving them somewhat equitable salaries or whatever. Really is a ploy to try to get people in the door, but that's neither here nor there. But they've adjusted their salaries to where they should be. I wonder if that will translate. Will that eventually? Because at some point, at the rate that they're going, and even with the minimum wage being increased, are they making those same adjustments across the board to other industries? And is that a permanent thing? Is that something that they're just trying to do temporarily? I mean, I wonder what that is going to look like in the very near future, because we're in it.
I don't know, but I don't see this current situation changing anytime soon. Not without some kind of major intervention, because truth be told, people are tired. And it's obvious that people are tired anytime people are not working and choosing not to work, and there are millions of support of alleged job vacancies, and people are still deciding not to go to work without unemployment.
Mm-hmm.
So there has been a shift, and I think that companies have far too long underpaid millions of people across all industries.
I agree.
And how in the world can companies make? But the thing is, but collectively, we have to say we as a culture have to decide that enough is enough. Like, there should have never been a Walmart. Walmart was able to become Walmart and make the money that it did because they've even had documentaries. When people get hired at Walmart, Walmart teaches them how to apply for additional welfare benefits. Why should you have a job and you still need social services?
Wow.
And they give them just enough hours where they don't have to pay them benefits, but you're still eligible for childcare. You're still eligible for food stamps because you're paying somebody $7 something an hour. That's ridiculous.
Yeah.
In the 21st century,
isn't there some sort of incentive for the company to do that? Isn't there something that they receive? Okay.
They get a tax credit for hiring people. Like, and it's like, so you're getting rewarded for underpaying people. So you're making money hand over foot off of taking advantage of people. But nobody has a problem with that. But then these same companies who pay politicians, then you have politicians who want to say that people are lazy because they don't want to work for less than $15 an hour in the 21st century.
In the United States.
Would talk. What'd you say?
In the United States.
Exactly. And then they want to talk about, well, fast food jobs were never meant to be sustainable. Fast food jobs were always for teenagers who wanted to start working. Okay, well, you tell that to the 75-year-old who's working because they have to pay for their medicine. Yeah. Tell it to them.
That's true. That's true. And they're still working. I remember seeing this little lady in McDonald's one day. I was like, wow.
One of my friends, when she was in grad school, it was a couple years ago, she was talking about this older man at the deli. She said, "Oh my God, I don't like him to fix my food because he moves so slow." So I said, "Do you really think somebody that age really wants to come to work and be bothered with that?" I said, "That man has to work. Do you think he's doing it for the heck of it?" I said, instead of doing that, you should hope and pray. Your prayer should be, God, I hope I don't ever have to end up like that.
Amen.
That should be the prayer. It shouldn't be, oh my God, I can't. I'm like, that's a problem with people. He doesn't want to be there, but it's all about you.
Yeah. Yeah. That's right.
Because I'm not even nowhere near 80, and trust me, if I didn't have to work, I wouldn't. It's not what it's cracked up to be. That's why you got to find something you really, really like. Because I'm telling you, it is a mess.
Yeah, it's gonna be interesting how this. We in a different time. We're definitely in a different time, and
yes,
there's no more that going back to what you thought was normal. That doesn't exist anymore.
No, thank goodness, because it wasn't great to begin with.
Exactly. But the nostalgia of it all, you still have people. Oh, I wish we could do. Please don't.
But it is really, now is the time for people. Now is the time to learn new skills. Yes. It is the best time to reinvent yourself. Yes. God knows it is.
Say that.
It is the perfect time.
Spill that tea. That's the tea right there. Spill it.
Yep. And just take advantage, learn what you can. I mean, you have years. Nobody could have ever predicted that. Let's say 10 years ago, that people could go to a 6-month coding boot camp and come out after 6 months, and your first job is paying you $85,000 a year. Mm-hmm. Nobody could have told you that.
Yep.
But it's all about the advancements that have been made in technology and what the market needs.
Yeah. That's the truth.
So we got to get these people, especially people of color, to get that money. There's a skill to negotiating, and you have to, like, I tell everybody, if you don't do anything else, at least just counter their initial offer. At least it's like $2,000.
At least. Have your desired goal in mind, but at least.
I mean, because I don't think that a lot of us don't even realize how underpaid we are.
Or, not only that. So, of course, definitely you want the money in your pocket, but then there are other benefits that are negotiable as well. So negotiate that time off, negotiate, conferences, or especially if you're certified, you have credentials that you need to maintain in order to stay employed and do the work for them. Negotiate that, hey, I need to get an annual conference, or I need some kind of something, because they try to cut and slash everything. So negotiate all of that as well. There's lots to negotiate. You're absolutely correct on that. I that used to drive people be like, well, they don't pay me. I had to take my PTO in order to come to and be like, really?
See, then I wouldn't be in attendance.
You to have this, but they're making you pay for it. Really?
Exactly.
Yeah, there's a lot to do. Well, that was the tea for the day. Yay! So we have to. So I see another ebook in your future. The Fine Art of Salary Negotiation. I'll put that in your spirit as well.
All right, because I mean, it really needs it, because I mean, especially us, like we just you have to get
whatever
to it.
is given, usually.
Exactly, and it's like, and it's never what you're worth.
Exactly.
Never.
That's right. Know your worth. Know your worth. I say that all the time. Know your worth.
And you can, and because listen, these people want you for a reason. It's not charity.
Exactly.
They want you because you have the skill. So make them pay you.
And what you're bringing to the table is more often than not more than they even anticipated. Because we're very creative. We do some things.
Exactly. Well,
we find ways and we get stuff done. We do things. So you're paying for that as well.
I'm going to leave you with the parting story.
Okay.
This happened 2 years ago. I negotiated. I was hired I negotiated the salary. I asked them for um like $5,000 more than what they offered. So I had to I had to have another round of interviews for that. I had to meet with the chief medical officer for them to approve. So I had my little half an hour conversation, and they approved it. So I was told that my position was going to be salary. And you know, when you're salary, your benefits start sooner than when you're hourly.
Correct.
So when I go to work and I'm starting my onboarding, they had me down as hourly. I'm like, no, that's not what I was told. So then when I call HR, you know, then they want to come, oh, well, it's a mistake and blah, blah, blah. I said, oh, no, no, no. I said, that's not how do you make a mistake like that? I said, and I said, this is not a new position. So me, I quit. I left. Do you know those people? The vice president of HR called me the next day. I didn't even answer the phone. She called 2 days in a row. So the second day I answered. And I said, this is unprofessional. I said, first of all, I said, how do you make a mistake like that? And then it's not even communicated properly. Then you want to, oh, it's a mistake. No, no, no. Because first of all, what you need to do at the very least is you need to honor what was told.
Exactly.
So long story short, they were like, well, is there any way that you would, you know, we really, really like you, you know, and because in that time frame, I'd already helped this woman with this data analytic project. So she must have told them that I was good or I was valuable or whatever. Mm-hmm. So because they brought that up. So I told them, I said, well, since we want to renegotiate, that's because basically what you have done is you have effectively renegotiated the terms of my employment when you changed my benefits from when you changed it from salary to hourly. And so since negotiations are open, I'm going to need another $5,000 to come back. You know, I got it.
I know you did. I know you did. I know you did. Wow. Well, yes. Well, on that note, spilling that tea. Again, I'm dropping that in your spirit, that whole ebook on. And here's the title, The Art of Salary Negotiation. Write that down.
Okay.
Oh, well, thank you for joining us. For those in the Clubhouse room, Cliff and Terry, thank you for being here. Don't forget to reach out and network and connect with each other, and those of us in the room, follow us. Don't forget to hit the little green Clubhouse so you're notified every time we have we open up, and we generally open up every Saturday morning at 9 a.m. For those of you on our YouTube channel, my co-host / moderator is the coding nurse, and he has a channel as well. Feel free to go over and take a look and listen to the additional tea and knowledge that he drops on the coding nurse YouTube channel, Coding Nurse YouTube channel. Wonderful information. He's always dropping gems and just a wonderful, valuable resource. You all know that I believe in resources, and I've just been so blessed to have connected with him and allow him to share time on my channel where, you know, we collaborate and go back and forth and give opinions and bring the tea to you every Saturday morning at 9 a.m. Eastern Standard Time. So feel free to like, share, and subscribe to our channels. And we look forward to seeing you again next Saturday.
All right. Everybody have a great week and weekend.
Thank you. You too.
All right.